Hello, my name is Jeffrey Leonard. I'm Chief of Pediatric Neurosurgery at Nationwide Children's Hospital, and I'm here to talk about pediatric neurosurgical emergencies, their evaluation, stabilization, and treatment. These are often anxiety-filled situations. These are things that at times can lack evidence, that can have very significant opinions associated with them. However, one must remember when dealing with these high-intensity situations that complete teams are required to achieve excellent patient outcomes. And because in order to stop locomotive, you must have an entire team. A single person is as this movie showed, a single person is incapable of stopping a speeding locomotive, and the value of each of the various team members must be appreciated. What I'm going to use this talk to both review traumatic brain injury and the emergent situations within it, as well as spinal cord compression, and finish last with our silent killer, hydrocephalus. We'll talk about some conclusions at the end and some of the things I've learned along the way. Now, case one is this is a case of a young child that was admitted. These are CT scans separated by approximately 2 hours, showing intracranial hemorrhage, as well as loss of gray-white differentiation and swelling. The child received full medical and surgical treatment, including mannitol and a hemicraniectomy, and as well as management via TBI protocol. These ICPs were refractory to medical treatments. And as you can see, we've already done a hemicraniectomy. The child lost all brainstem reflexes and had care withdrawn on postoperative day number 1. This is in stark contrast to the following case, which showed evidence of a development of an epidural hematoma separated by a couple of hours, where the child dwindled and deteriorated while in the hospital. This child received medical treatment, albeit mannitol, as well as a hemicraniectomy as the child deteriorated and developed a fixed and dilated pupil. These child had ICPs that were well controlled after surgical treatment and had a 5-day ICU course. And after extubation, spent 7 days on the neurosurgery floor, as well as undergoing acute rehabilitation. This child did well. This is evidence of the helmet this child was wearing, and ended up walking out of the hospital on their own volition. These are situations that are anxiety-filled, and at times I like to say we have a very short amount of time, where I like to have these things decompressed within 20 minutes of diagnosis. We do this by recognizing that the care for these patients starts in the pre-hospital setting. We try to avoid hypotension. We manage with isotonic or hypertonic fluids. The one caveat is we absolutely avoid hyponatremic solutions. We have system-based recommendations because oftentimes these injuries and stuff can occur in hospitals that are 2 and 3 hours away. We have organized trauma care systems necessitating transfer of patients with severe TBI with GCS of less than 9. We minimize transport time and take a history prior to transition to the hospital. What tests were performed? What's the child's seizure history? Was there recreational drug use? Was there possible anoxic injury, as well as loss of airway? Was CPR required in resuscitating this particular patient? These are all pieces of information that help us evaluate whether a child is safe or stable to go to the operating room. We use a number of labs, including CBC, a BMP. We often type and cross them, as well as measure coags. We evaluate other sources of injury. The goal to scanner from through the emergency room is 20 minutes, with another 20 minutes to make it to the operating room within our golden hour. We oftentimes will evaluate these children with CT of the neck to identify any cervical spine injuries, and use the FAST scan or the chest abdomen CT to evaluate for intra-abdominal or intrathoracic injuries. Reviewing a few of the common things that we see, obviously this skull fracture that you see here was a child that we took care of at Nationwide Children's Hospital. This no one will argue with. This is scalp laceration associated with an underlying skull fracture. These are important because you first have to identify the dura and repair it, removing all foreign objects from the surrounding area. This allows for and prevents the formation of intracranial abscesses. And if the dura is not appropriately approximated or repaired, this can become a much larger endeavor down the road, as the CSF pulsations cause the dural opening to increase gradually. What should also be said in this point, with scalp lacerations that occur in the really young individuals, need to be dealt with and sutured or controlled in a very rapid fashion, because These children can experience hypotension for profound blood loss from a simple isolated scalp laceration. We also watch out for occult fractures, which can take a non-emergent situation and turn it into an emergent situation. These tend to be long shaft or projectiles. These are not necessarily high velocity and may show as a simple puncture wound. This is one seen at an outside hospital that turned into a neurosurgical emergency because of the development of intracranial abscess. These can often be at high risk for infection, yet when you look at them on their CT scan or skull x-rays, you see they are very innocuous and do not show a lot of outward signs of injury. However, is the one that we all dread. This is an epidural hematoma, and when the system is functioning properly, it's a runaway train that can be stopped. This is bleeding between the skull and the dura and can be caused by either skull fractures or epidural veins or arteries. These are true neurosurgical emergencies. These are patients that can recover well if the injury is identified in a rapid fashion. These are children that come into the emergency room walking and talking and can dwindle over the course of their stay in the emergency room or in the hospital if their intracranial injury is not identified. This is actually an autopsy picture showing what an epidural hematoma looks like, where it's compressing the surrounding brain and overlying dura. This is technically quite a simple procedure, as this child shown with both a subdural as well as an epidural hematoma. The crescent-shaped epidural hematoma is visible, and immediately superior to this, you see there's also an extraaxial fluid collection as well. Emergent evacuation of this and correction of the midline shift allowed this child to recover fairly well from their injury. These can be easily taken care of, including when they're associated with a skull fracture, where the skull fracture is evacuated, the underlying bleeding is controlled, and the brain in these children ends up refilling that space. These are very gratifying procedures because the outcomes of these children within 2 to 3 days is quite good as they wake up from their severe traumatic brain. Subdural hematomas, though, are quite different. This is between the brain and the covering of the dura on the other side. These can often be associated with worse outcomes because the mechanism of injury required to produce these is often much greater. These are often associated with brain contusions and lacerations and are prone to cause seizures. So more often than not, we tend to treat these patients with anti-epileptic medications and evacuate these with the same rapidity and precision that we treat the epidural hematomas with. This is actually an autopsy specimen showing membranes within the subdural hematoma, and the fact that these can be as equally problematic when you're dealing with them as can epidural hematomas. This is important because they generally are things that can be fixed, that if properly treated, the children can have excellent outcomes. If they're not treated in a rapid fashion and the mass continues to accumulate, things happen that are not necessarily compatible with life. You first get loss of venous return from the brain, and the CSF and ventricles start getting exceedingly small. As the pressure goes up, or the ICP goes up, you start getting mass, you get edema within the brain, you start getting loss of arterial blood as well as loss of cortical activity. As the brain begins to herniate, a structure such as the brainstem is shown in this, where the uncus, or the very medial portion of the temporal lobe, ends up herniating against the uncus, causing the dilated pupils and loss of the overall level of consciousness. This is true because the skull is a fixed compartment in most kids. Only in the young kids do we have expansion of the brain, but they have far more severe traumatic brain injuries in the young children, especially with non-accidental trauma. If this is not dealt with in a rapid fashion, these are quite dramatic pictures that can occur, indicating that this ICP is quite high. The brain swells, making it very difficult to close this at times, making sure that as neurosurgeons, we have to deal with these entities in a very rapid fashion. This is not a very good situation. This child ended up not doing very well after decompression or a hemicrectomy. Other things that we do in emergent situations is use ICP monitoring to monitor what the ICP is within the brain. We can use a variety of instruments to do this, including ventriculostomy, intraparenchymal monitors, and subdural catheters, depending on whether we've left the bone off or not. We have level 3 evidence to recommend use of ICP monitoring in severe TBI. though the recommendations, it was not to assume normal ICP with normal head CTs. We can have over 80%, if the child has an abnormal head CT, about 80% of the time we will have an abnormal ICP. Why to monitor them? A third of the children with severe TBI have elevated ICP upon initial placements, and half have elevated ICP during monitoring. There's indirect evidence that shows improvement in outcome, because at the end of the day, what we want to show is that we're actually perfusing the brain. We want to ensure that the brain is oxygenated, and we do this by measuring the CPP. The CPP, or called cerebral perfusion pressure, is necessary because the MAP, or the blood pressure, must be high enough to drive the blood flow to the brain against an elevated pressure. These, if they're greater than 40, we can often maintain cortical function when the autoregulation in the brain is not functioning in an adequate. What is a safe ICP? A safe ICP for pediatrics, which is the least studied when you compare adult and pediatrics, is less than 20. There's not enough data to age discriminate, but we generally recommend treatment if we're able to demonstrate an ICP of less than 20. What we also show is that we can do our autoregulation curves with hypotension, chronic hyper or hypotension, but the goal of these is to show that we preserve cerebral blood flow over a wide range of cerebral perfusion pressures over all the flat part of this line. This is important because what we also want to do in the acute situation is prevent any other secondary insults. While we cannot prevent the actual occurrence of the injury, well, we can, but by the time we get them, the injury has already occurred. We can also attempt to minimize the elevated ICP. One of the first things utilized in the emergent situation is hyperventilation. Now, with this said, I'd say is that prophylactic severe hyperventilation, or PCO2s less than 30, is not suggested. This is important for everybody to understand, because what happens in this situation is you begin constricting the arterial supply to the blood and can actually cause ischemia. This has been shown in multiple studies, including PET scans as well as xenon CTs, and use of hyperventilation is only recommended when you're emergently trying to reverse transtentorial herniation, is being shown in this patient, where you have where the right eye on this particular patient is dilated from compression of the third nerve. With hyperosmolar treatments in the emergency room and in acute situations, one of the most common things that we use is a hypertonic saline. We have a variety of concentrations, albeit 3%, 6%, and 23.4%. We use boluses as well as start drips of these to maintain sodiums in the 150s in an attempt to reduce the swelling within the brain. Boluses of 23.4 is suggested for refractory ICP. And do not forget about mannitol, because that is also equally used as a hyperosmolar solution if we're attempting to change the swelling of the brain. What we do in these situations is also treat according to a TBI protocol. And where this starts in the pre-hospital setting, verifying that we're maintaining normal thermia, we're maintaining adequate head of bed, we're maintaining and treating any coagulopathy. We have a variety of tiers. We have several tiers associated with our ICP pathway. But what this does in conjunction is there's no one set of good evidence for each of these various interventions. However, this is a agreed upon pathway where people are judged on, and QI processes are focused around ensuring compliance to this pathway. And what this does is it reduces error. It ensures a more uniform treatment for patients with traumatic brain injury, and both within pediatric critical care medicine as well as my own publications in Lancet has also shown that use of these kinds of protocols does improve outcomes in these emergent situations. This is our second tier therapy, showing additional neuromuscular blockade as well as CSF drainage should you run into problems with treatment of these very severe injuries. With that brief review of traumatic brain injury, I'm also next going to cover spinal cord compression. The most common causes of spinal cord compression in the pediatric population is the spinal cord tumor. Treatment options for children with spinal cord tumors must be to relieve compression from this tumor and alleviate the neurological symptoms. Outcomes often depend on both your diagnosis as well as the time to decompression from the onset of symptoms. And this is just a brief review so that people understand when you're faced with this particular situation, either in clinic or in the emergency room, that you have a reasonable idea on deal with it. This is a review of 70 patients with spinal cord compression. Extradural tumors were the most common at 71%. The reason I mention this is because if they're epidural, they're fairly easy to decompress. So they are surgically over several levels, very easy to decompress, and surgery should be concerned. Laminectomy for decompression was offered to those with paraplegia less than 96 hours, with pain also being a very common symptom. There's also evidence of intradural tumors, generally outside the spinal cord, such as medulloblastoma. So if you see somebody, you first have to determine whether it's an intradural or extradural tumor, and then be able to determine what the most likely diagnosis is. This is a 15-month-old with right leg weakness and urinary retention. Because of this neurological deficit, they referred to neurosurgery for evaluation, showing significant spinal cord compression. This ended up being a neuroblastoma, and the child underwent a 3-level laminectomy, which is on the outer limits of what reasonable decompression would be. Chemotherapy was started 3 days later. The child recovered all function in this particular case, and ended up doing very well with complete resolution of their symptoms. This is because approximately 5 to 15% of children with neuroblastomas have spinal involvement. Less than 2 years of age have biologically favorable disease and excellent survival. However, a large portion of these patients with spinal canal involvement has symptoms and signs of spinal cord compression, which include paraparesis, pain, kyphosis, and bowel and bladder dysfunction. So what you need to ask these patients seeking to evaluate them is, when did the symptoms start? When was the last time that you remember the legs moving? Are there any other signs of tumor? Is there a big lump on the back? Do you have a lot of cafe au lait spots? Or is there any other family history of tumors? Giving you a likely reflection of what the diagnosis would be in deciding whether this is a tumor that's going to respond to chemotherapy. First of all, the second thing is the goals of treatment. You must figure out what your most likely diagnoses are going to be. We also talk about decompression as giving room for the tumor to expand before chemotherapy takes effect. What people sometimes don't understand is that it may take 2 to 3 months for the chemotherapy to begin taking effect. The tumor is going to grow during that time, and if you've not given that enough room, there's going to be ongoing spinal compression and perhaps progression of neurological deficits. You also must consider the lifelong effects of your decompression, determining whether you've just caused spinal instability in a 3-month-old that they'll have to deal with and eventually treat surgically. And you also, in somebody with systemic disease, have to determine what the delay in chemotherapy is going to do to the child's overall prognosis. This is a study showing intraspinal neuroblastomas. In 576 patients with neuroblastomas, there's 51 with intraspinal extension, with 34 with signs of spinal cord compression. This is important because this is one of the studies showing what kind of recoveries you saw. Surgical therapy is usually reserved for benign variants. Duration of symptoms less than 4 weeks is associated with improved outcomes, meaning you can reverse this if their duration of symptoms is less than 4 weeks. Optimal therapy is still debated, where some with neurological findings ended up going decompression and others getting started on chemotherapy. So this is still a portion of the debate and individualized based on patient, the symptoms, and the number of levels requiring decompression. Symptomatic spinal cord injury in neuroblastoma is diagnosed when most patients are only unable to walk. Overall frequency of symptomatic spinal cord injury is 5%, oftentimes with long tract signs and motor weakness. Failure to recognize this is not unheard of, because most people are not looking for it when they examine patients either in the clinic or in their emergency room. Bladder function must be assessed. A child must not be determined to be functioning normally if they're still in diapers. You must determine whether there is evidence of an anal wink, and are they appropriately emptying their bladder. Motor function is difficult to assess in young patients. And always, if they are ambulatory age, walk them, because children that cannot walk deserve immediate emergent attention. You need to ask what the most likely diagnosis. Will steroids have an effect? And determine the extent of resection. Will you have to go anterior or posterior, and how many levels? Because that'll determine whether the emergent nature of your important, because you also must determine whether it's something like an infantile hemangioma. These are things that respond very well to non-surgical treatment. These can shrink dramatically and can have almost complete resolution of neurological findings, which is why we wanted to achieve a diagnosis in this situation in a relatively rapid fashion. Now, having a very broad differential when you're dealing with spinal cord compression in the pediatric population is important, because surgery is not the answer for all these children. CSF, however, is one of the most common things we do, and one of the things that does cause some of the biggest headaches and problems for both families as well as the neurosurgeon. It is the most cases, and oftentimes the most simple of the cases that we do. However, it is the most common medical malpractice case. I'm going to talk a little bit about the cases that we're seeing and talk about the role of surgery. What we do in this is a 7-month-old X27 week who presents with hydrocephalus and a seizure. This child that had multiple VP shunt revisions requiring bilateral shunts as well as enterococcal shunt infections. The child presented with increasing head circumference, listlessness, and irritability. Do we take them emergently to the operating room to fix this and replace one of 2 shunts? If so, which one? Because all of the cysts at this point were quite large. What people need to realize is that hydrocephalus is a very common disease entering entity in pediatric neurosurgery. It's important to recognize that this is approximately 30 to 35% of the neurosurgery practice. And because of this child had not gotten sick previously, and it took a long time when they have, we chose to not do this case emergently at Nationwide Children's, but instead brought them in the next day and ended up doing endoscopic fenestration of all of their cysts, and was able to really consolidate their shunts, and overall had a great outcome with this. This is important because I'm introducing the fact that if thinking about it, there are alternatives to shunting as well. This is what I'm showing here on the picture is an endoscopic third ventriculostomy. Now, this is something that is not done well at 2 o'clock in the morning under emergent situations. But if you're able to treat these kids and understand, how quickly they are to deteriorate, you can actually begin to think about making them shunt independent, because approximately 40% of our shunts that we place will fail within the first year. It's not a good thing other than to say that it's job security for the neurosurgeon. Now, in order to alleviate this or begin to develop protocols and processes to improve upon these outcomes in this particularly troubling entity that we treat in pediatric neurosurgery, we actually have a hydrocephalus research network, which is made up of 10 of the largest institutions in treatment with hydrocephalus, of which we're a part of. This is important because what it does is it allows us to identify risk factors for shunt malfunction. Who are the folks that are going to get worse emergently? How do we treat them, and what do we need to follow? This is important because what the HRN has done is it allows us to establish outcome measures. How are these patients being admitted to the hospital? How do we utilize healthcare resources? And how do we monitor some of our new procedures? And is it actually better than actual shunt placement for treatment of hydrocephalus? This is important because this is a common procedure, and we must also determine what's our incidence of infection as well. Infections are very difficult to treat. They occur approximately 2 to 4% of occur in approximately 2 to 4% of shunt placements, and are significant detractors or cause significant neurocognitive problems in children if they do undergo an infection. We are very attuned to this, and actually do a lot to try to improve our overall prognosis, both in the emergent and elective situation. Now, I'd like to end this by saying there are a multitude of diagnoses that can produce neurosurgical emergencies. To first recognize that we have multidisciplinary teams in these situations that are important for treatment of these patients. We must recognize the timely recognition of neurological impairment is critical, and we must also develop standardized processes to help reduce errors and improve outcomes. When you do this, you can build something as large as the largest building that's present within the UAE. It's quite impressive to see what a good team does. And with that, I'd like to say thank you very much for listening to me for this half hour, and I'll be happy to take any of your questions.